Okay. Hello, everyone. Good evening. Thank you for joining us tonight. Really appreciate you guys taking the time to be here with us. My name is Dr. Alex Puidapa. I'm an interventional radiologist, and I'm joined by my colleague, Dr. Gordon McClellan, who's also an interventional radiologist. We're really excited to speak to you guys about what's called benign prostatic hyperplasia, or BPH, and a minimally invasive treatment option called PAE, or prostate artery embolization. So without further ado, I'm gonna send it over to Dr. McClellan, and he will go through a PowerPoint. And then towards the end of the talk, we'll have some common or frequently asked questions, and then we will try to address all the questions that you may have that you can share in the chat.
All right. Thank you, Alex, for that introduction. Um, I'm going to share this screen with you so you can see this. I hope everyone can see this. Let me know if you can't.
Yeah, we can
Um,
see it.
all right, great. So, benign prostatic hypertrophy and prostate artery embolization, that's our topic for discussion tonight. I've been in this practice for the last 2 years, more or less. I'm almost up to my 2 year anniversary, and I've done over 1,000 of these procedures in that period of time. Um, it was uh, it was an interesting thing to take me out of my retirement from academic medicine to come back to do these procedures, but I've enjoyed every minute of it. I'm really glad that I've been able to take care of many patients like yourselves. Okay, so let's get this to go. All right, so we are IR centers. We do interventional radiology procedures, which in our area for this site is prostate artery embolization, because we're related with the Colorado Urology Group, which you may have noticed is also part of OneOncology now. In our practice, it's myself and Dr. Jim Hart, as a physician I've known for probably 5, 6 years since I've been here in Colorado. He and I worked together when we were both up at the university, and he was recruited by Alex and his group to be part of our family here in Colorado. All right, so what is benign prostatic hyperplasia? Um, Basically, it means an enlargement of the prostate. It is non-cancerous, and it happens to some degree to every male. Okay, over 50% of men will develop BPH as a syndrome, but everybody has some growth in their prostate as they age. And by the time you're 80 years old, 80% will have some need to urinate more frequently, have a decrease in the strength or speed with which you urinate. That's the weak or low stream, um, or difficulty starting urination. And the other one that's really problematic for a lot of guys is that you wake up 3, 4, 5 times a night, and it makes it difficult to urinate. Um, and you may have the sensation that you're never ever really completely empty. Like you go up to pee at 2 o'clock in the morning, you urinate, a little bit comes out, you sit down, you feel like you got to go again, you go again, and a little more comes out. That's a symptom some of you may be able to recognize. So the prostate sits just below the bladder. It surrounds the urethra, which is that pipe that comes from the bladder to the outside, and it carries the urine out of the body. And when the prostate enlarges, it squeezes it, making the urination more difficult. It makes the bladder actually have to work harder to push the urine through the obstruction. Some of the descriptions are that you can't hold it to pee. You got to get there right away. If I got to pee, I got to pee now. Airplanes are particularly problematic sometimes. Getting up 2 or 3 times at night is difficult to urinate. At our age, in our 50s and 60s, as we get older, getting up once a night is pretty normal. When you start to get up 2 or 3 times a night, that's a lot. I've had guys who've told me they get up as much as 6 or 8 times at night. I myself, who had this procedure about a year ago by Alex's partner Sonny, um, I was getting up 6 times a night. So I kind of know what you're feeling as a patient as well. Um, keep going. Um, Age is a factor, mostly occurs over 50, and family history. If your brothers, your parents, your father, and grandfather had this issue, it's more likely for you as well. Right. This is what sizes are all about. And I will stay at the outside. I don't think size is critical as a piece of information before we do a prostate embolization. nor is it really a primary concern for me as to how the procedure responds. Size is a number, just like age is a number, but your symptoms are the things that we're looking for. But just to give you a reference of how to think about how big things are, this is a good slide here. Your typical prostate is about 20 cc's, all right, or grams, depending upon how you want to look at it. And a 20-gram prostate is about the size of a walnut, which is the typical size of a prostate gland. Ping pong balls are slightly bigger, so that'll be your 30 to 35 cc's, maybe half as much as big. Golf balls about double the size, about 50, 40 cc's. And then like the clementine oranges are getting into that 3 or 4 times. I see a lot of guys in this range, 60, 65, 70 cc's. And a tennis ball is about 150. And I've seen glands that are as big as 400, 500 grams. They're not common, but we see them. Most of the patients who come to us are in this range of around 100 cc's of volume. And then what happens afterwards, as the gland shrinks, it'll get a little bit smaller. And it also gets a little bit softer. So, treatment options. How do you deal with benign prostatic hypertrophy? Well, the first thing to do is think about, we go from sort of least complicated to more complex as we move through things. In medicine, most people will start with medications for almost any procedure. There are two different classes of drugs. There's the alpha blockers, which are things like you might be on tamsulosin, also known as Flomax, and the 5-alpha reductase inhibitors. Those inhibit an enzyme that can help reduce bladder symptoms from the bladder being irritated and the obstruction being. Those are things like finasteride, dutasteride, and the like. They reduce symptoms, but you have to take them continuously. They don't really shrink the prostate that much, but they will have, and some of them have some side effects, and we'll go over some of that in a bit. But I've had some patients who've told me about side effects such as dizziness and lightheadedness and things like that that relate to these medications. The medications can also result in retrograde ejaculations, which is one of the things that concerns a lot of men. The minimally invasive options are the ones that are the easiest ones. There's a number of urological minimally invasive options. The Urolift, which they put staples in to hold that pipe open, or the Rezūm, which is localized steam therapy to sort of open up the middle of the prostate so that there's more space in that pipe. And then the prostate artery embolization. They avoid major surgeries. They can be done in outpatients or ambulatory surgical center settings. They have a short recovery time. Some may use anesthesia, some don't. But the idea being that it's a little bit less of a major surgery than the more advanced surgeries like the TURP, or which is the transurethral resection of the prostate. This is the original treatment for benign prostatic hypertrophy. It's been around for probably 50 years. And there are newer innovations in the TURP, such as the green light lasers and the aqua ablation, which uses water to really sculpt out the prostate. That all told, if you added up all of the procedures that urologists do, there's 8 of them. And they are all based upon trying to make that pipe bigger from the bladder to the outside. The surgical approaches generally require anesthesia, a hospital stay, and then there are some sexual side effects, such as the retrograde ejaculation, some erection issues, and things like that can be caused by some of those procedures as a complication of the procedure. So it sometimes happens. All right. So the thing about the PAE is if you have a Foley, 85% of the time we can get that Foley out. There's no stitches needed. There's no Foley needed if you are going to have the procedure in the first place, unless you have a history of having retention. And then the embolization just uses the tiny catheters that I use to work inside blood vessels to get the particles to the prostate so that the prostate can have its period of inflammation, making the gland softer, and also shrink about 20 to 40%. It's a same-day procedure done in an outpatient office with no need for general anesthesia. And in fact, the only thing that really hurts about this procedure is the numbing medicine at the very beginning procedure. These are some of the drugs, the alpha blockers. They relax the muscles around the prostate and the bladder neck to improve urine flow. They work pretty quick, but you have to take them indefinitely, and sometimes they'll double up those drugs. The 5-alpha reductases, the finasterides and stuff, they block the hormones that cause the prostate to grow, and they can shrink the prostate modestly. Typically, it'll take 6 to 12 months, and the side effects can include low libido and sexual side effects in some men. It's best suited for the moderate prostate enlargements and long-term daily medication. And then lifestyle changes are something that your urologist should be recommending to you no matter what. A lot of the guys who will come to us already have adjusted their fluid intake before bed. Limiting caffeine and alcohol can be really important because both caffeine and alcohol can irritate the bladder. And certain foods as well can also make things have an issue. Being healthy, having a good healthy weight, and having an active lifestyle supports prostate health. So if you do these things and you exercise and you have just general overall well-being, good cardiovascular health like daily exercise, doing some cardio work, eating healthy, and avoiding things like alcohol and caffeine and other bladder irritants, those can help a lot with your prostate symptoms, whether you have no procedure and you're just on medication, or you go up to having TURPs and everything else. No matter what you do in order to treat the PAE, adjusting your lifestyle so that you can function better all around is better for you anyway. And it'll help with your symptoms. Here are some of the treatment options. We're going to go over Urolift and Rezūm and aquablation as the alternatives to the prostate embolization. I'll show you some videos which will show sort of what's going on with that. Those reflect the sort of minimally invasive to more invasive approaches. And when I say there's 8 procedures, the aquablation is probably a good example of a TURP and a laser TURP as well. These are some of the things that are going on. So like in the Urolift, what they do is they go up through your penis into the urethra, into that pipe, and they sort of push the tissue back and deploy these clips that are going to, it's like a staple that'll hold the prostate open. And it's typical to have like 2 clips or 4 clips. It depends how long they have to treat. I've had a few guys come through who had this procedure and it worked for 3 or 4 years. And then after 3 or 4 years, the prostate gland grows back and it causes symptoms again. That happens with every procedure that can be done on the prostate because that's what prostates do is they grow back. The second thing up here, this is the Rezūm, where you basically put a little needle and inject steam to destroy the tissue that's near the urethra. And then the bottom 2 pictures are an example of the aquablation. They do put this is under general anesthesia. They'll put an ultrasound probe in your rectum, and then they'll put their devices in through the penis, and they'll get into the prostate gland. And then when they start the water vapor, it sort of scrapes back and forth from the front of the prostate to the back of the prostate, and they can adjust it, the distance based upon the ultrasound, and it'll sculpt out probably the middle 80 to 90% of the prostate will be removed with this technique. And obviously a much more invasive procedure than the prostate embolization. So what do you need to know about PAE? Every one of my consults, I actually cover all of this. The procedure takes somewhere between 30 and 90 minutes to do. And 90% of men will have an improvement in symptoms. And it's a completely outpatient procedure. The only time we've ever had to send a patient to the hospital is because they had a medical problem that wasn't related to the procedure itself. And you can have heart attacks anytime, anywhere. And if you do, we have a ability to do codes, and we'll call 911 and get you over to a place that needs to take care of your other general medical problems. But we've not seen too much of that because most people are actually pretty healthy, and this is a benign process. So, are you a candidate? Look, the main thing is, do you have a diagnosis of BPH? Often the pills have not worked well enough, and your symptoms are typically affecting your daily life in one way or another. A lot of you guys will be pretty dismissive of symptoms. This is, oh, it doesn't matter that I wake up 4 or 5 times a night. And you'll be sleepy and you'll be drinking lots of coffee. You'll be fighting your way through your day, getting, whatever work you're doing done and whatever activities you do done. But if you're not sleeping well, your heart's not healthy either. So these are things that are important for your overall health as well. Um, People who go the PAE route often want to preserve sexual function because we don't carry any significant risks of retrograde ejaculation or erectile dysfunction. There is one study that suggested that based on the SHIM survey, that the erections could get a little better after prostate embolization. I tell most guys that I don't think that was a very strong study. So I tell most guys that if their erections get better after the PAE, then just consider yourself lucky. If you want to avoid surgery, in general, this is the way to go. And the other thing is, if you have prostate cancer, this procedure is not going to treat that. We do this procedure for prostate cancer patients who are choosing to undergo radiation therapy because doing the procedure can help with symptoms after the radiation, but it does not specifically target the cancer. And so if your PSA is elevated, you need to see your urologist. You need to have a plan in place to make sure you don't have a prostate cancer. And if you have one, how you're going to manage treating it. Your urologist is going to be your best advocate for that because they will do active surveillance in some, they'll do more invasive surgeries for other, and they will get those prostate cancers treated. We know that prostate cancer is common and present in over 90% of men who are 90 years old or more, based on some autopsy studies. And many of those men didn't even know they had prostate cancer, and it may not be a cause of death, but there are some prostate cancers which are very aggressive, and having a urologist who will help you through that process is very, very important. So you don't miss something when it's easily treated and get to the point where it spreads somewhere and it becomes a much more debilitating disease. So I can't emphasize enough the importance of a collaborative relationship with the urologists, as we have it here with Colorado Urology and IR centers, because I don't have the issue of a guy having a prostate embolization and then going on to have a prostate cancer later because it was missed because the patient didn't have a urologist that was following them. So this is how prostate embolization works. First, we do a tiny nick right in the crease. I use the groin. We can use the wrist, and I've used it once or twice, but I find that with the groin puncture site, I have much more control over what I'm doing, and it's a much more efficient procedure. But we puncture the groin, we numb it up, we put a needle in, and then we use our X-ray guidance to guide catheters and wires up into the arteries that feed the prostate gland. And once I put these tiny little microcatheters, which are, probably the size of a piece of spaghetti, and we get them into where the tip is, right in the artery that feeds the prostate. And then we inject these microscopic spheres. These spheres are basically all based on this molecule called polyethylene glycol that's been in medical use as an implantable probably since the early 20th century, 1910s, 1920s. So it's probably over 100 years of use of this class of material. And these are all FDA approved devices that have a lot of history behind them. So they're basically inert. We fill up the artery inside the prostate gland, and that cuts down on the blood supply and leads to about a 20 to 40% shrinkage in the prostate. It also causes initial inflammation, which helps make the gland's tissue softer. And it's that combination of a softer gland and a smaller gland that leads to less pressure on the bladder and the improvement in the symptoms. And then we remove our microcatheters and we close the artery with a little device. And I've moved to using a device called a KELT, which is a little metal clip. It clips the artery closed, and as the artery heals, it sort of pushes the clip into the fat next to the artery. You won't notice it being there. It won't do anything for you afterwards, but it is the most effective closure device I have used in 25 years of doing this kind of work. It is so effective that in some of the patients who have histories of stroke or heart disease with cardiac stents who need to stay on anticoagulation, I do not stop the anticoagulation because the closure device is so effective. You might get a little bit more bleeding if you're in that situation, or bruising around the puncture site, but you won't get significant bruises and what we call pseudoaneurysms and complications of the puncture site. I've used it in probably over 700 cases now, and it's really quite effective. This is kind of the graphic representation of what the procedure looks like. What we do is we put the artery in, and we get particles into the prostate itself. This is what it looks like, and then over time it'll shrink. It's usually over a period of about 6 months. Oops. This is sort of the graphic of navigating up and over from one side into the other, getting into the artery that feeds your prostate gland. And then, we call it the inferior vesical artery. It's the official name for this artery because it feeds the lower part of your bladder. But when you get into the last branch, it'll feed the prostate, and then it causes it to shrink down. This is a case that Dr. Bagla, one of Alex's partners in Virginia, did. This is, they put the catheter in, they take some pictures, and then you get this roadmap that we can follow. This is something we tell the patients: if you want to watch it, just turn your head to the left. We can turn a screen so you can see it. You can see you get in, get your microcatheter into that branch. Then when you inject, you see the prostate. It looks like this. Sometimes we'll comment, this is a prostate on a stick. And then we inject the particles with very low dose contrast, showing us where things are going. And if we need to do runs in between, we can. And then you get the whole prostate treated. What to expect? You're going to go home on the day of the procedure. You might have mild soreness or bruising at the site of the puncture site. Most of my guys will get a little bit of bruising, probably about the size of a quarter or slightly larger after the procedure. And that usually will be most pronounced 2 or 3 days after the procedure. You should rest. You should drink lots of water because we'll have given you some contrast. That will help flush everything through your system. There'll be some pain medications that, we give you ibuprofen to take. We give you steroids to take. We give you a few other drugs. You should take those drugs if you need them. And that evening, typically a dose of ibuprofen later that evening. The steroids, we typically have you start the following day because we'll have given you some steroids during the procedure. And then there's some other medications that we give you that relax the bladder. It actually turns your pee orange, so don't get freaked out. You need to have somebody drive you that day because when we give you this procedure, we're giving you some sedation with the Valium we give you. You're not supposed to drive for 24 hours. It's okay to shower 24 hours later. So I tell everybody take the Band-Aid off in the shower the next day. You want to avoid heavy lifting and strenuous exercise for about a week. I often tell patients 4 days, and my nurses tell the patients 5 days. And basically, you want that puncture and that puncture site to be completely healed before you do strenuous activities, because you don't want to pop the closure device off and have a big bruise. Around 2 to 4 weeks is when all of those normal activities will return. You might feel a little stiff. I myself felt pretty normal after about 2 or 3 days, but I kind of pushed through a lot of things. I felt totally back to normal by about the 4th or 5th day. You can resume sexual activity as you're comfortable. I tend to recommend avoiding it for the first week or two, just because I don't want you to get an infection, especially if you've had a history of prostatitis or infections before. We just did this embolization. Give it a minute to let everything settle in. The urinary symptoms can often get worse in those first 4 days. That's why we give you a bunch of medications. If you're on any of the medications, continue to take those. And then about a week after the procedure, call your urologist to try to get those, to find out when you can stop those procedures. And the gland will shrink for about 6 months. The urinary symptom scores are typically done about 6 months after the procedure. And the prostate size reduction can be confirmed with imaging. So like I said at the beginning, I don't find imaging to be that critical. If your gland only shrinks 15%, but your IPSS score improves by 12 points, that's a success, okay? It's about the symptoms. If the symptoms get better, it was successful. If the symptoms don't get better, you are in that unfortunate, 5-10% who just don't get good results. And then it's important for the urologist to look for other things. Is there something going on with the bladder? Is there something going on something else in the system? And sometimes we'll repeat the procedure looking for other blood vessels that might have developed. But there are ways to deal with that stuff. This is not the end. This is just very effective for most people. So normal recovery, baseline urinary function, and it'll go up in that first week or so, and then it'll start coming down. And then by a month, it might be down and might improve a little bit over the next 3 months. But you're not going to notice this change very much. You'll notice this change. So it's important to understand that, it's a slower process than what you might be expecting with other urologic procedures. All right, outcomes and the evidence. Well, there's a lot of evidence. We've got 8 randomized control trials comparing PAE to TURP. And we know that it has a substantial reduction in symptoms with less adverse events. We know that patients with severe symptoms, that's an IPSS of over 19, it reduces it by 11 to 15 points. Durability is 5 to 7 years, and has no effect on erectile function or ejaculatory function. This is what we expect, a greater than 90% symptomatic improvement in most patients. Greater than 90% of patients will report a symptom improvement. Durability is 5 to 7 years. And generally 3 to 6 weeks are when you're going to feel results. I've had guys call me the next day saying it was a magical cure. That's probably overstating things. I tell most people just give it at least 2 to 3 weeks and see how it does. Improvements you may see. What I noticed is on the 4th day when the inflammation started dying down, my stream got stronger. My next day, I got up one less time at night. And over the course of the next several weeks, I had 1 or 2 things that just looked a little bit better, like a little bit less getting up at night, able to empty a little bit more completely, one thing or another. And after 2 or 3 weeks, I felt pretty good. So because I didn't feel bad, I didn't notice the difference between one day and the next when you feel pretty good. And that's just human nature. Insurance coverage, we pretty much have no issues with insurance in general, other than that they want to make sure that, you've got an indication to do the procedure. And, the questions I ask in the consult really often relate to that. If you've got bleeding, blood in your urine for any reason, even after procedures, it can be a good thing to document. And I always ask about it. I do try to get the size of the prostate when I can, because some insurance companies get very finicky about the size of the prostate, which ones they'll pay for and which ones they won't. If you don't have any imaging available, I might order an ultrasound or a CAT scan to try to get that information. It helps our pre-authorization team sort of get it through that insurance gauntlet. But they'll get that done. Some patients, might have procedures like a CT angiogram or an MRI before the procedure to map the anatomy. And over 1,000 patients, I've done that twice. And it's usually after I've failed to find it when I did the procedure the first time. And I'm looking for some weird vessel that's from somewhere that I didn't expect. And that, can be a problem-solving technique. On the day of the procedure, you want to wear comfortable, loose-fitting clothing. We'll have you take everything off, including your underwear, because we're doing a puncture at your groin. If you want to keep your own socks on, you can. We ask all patients to be at our clinic an hour before their scheduled procedure. So our 8:30 patient needs to be in the department at 7:30. And that gives us enough time to have the nurses place the IV. I go over all the risks and benefits, and we get all the pre-procedural work done before the procedure. And then after you go home, one of our team members sits down with you and goes over all of your medications and what to expect and how to do activities. We have everything's written out, and you'll be handed copies of that. I have had some patients who are in facilities that want second copies of things. Just tell us. In fact, I'll sign the drug regimen if it helps the facility with that being a medical order, and that's worked out pretty well for us as well. Because not everybody is walking themselves in. Sometimes we have family members who are powers of attorney, and the guys are in facilities for other issues, like, whether they're musculoskeletal weakness or whatever. Um, so I think I'm going to turn it over to Alex at this point, and we're going to talk a little bit about your questions. And these are questions that we've gotten over time, since putting this webinar up for registration. Alex, you
Yeah,
want to
yeah,
run through
no,
the
that was,
questions?
yeah, absolutely. Thank you, Gordon. That was an excellent presentation, really thorough. Thank you for that. I was trying to answer some of the questions in the chat as you were going on, and some have been coming through. But here are some of the common questions that we do get about PAE. And I think you addressed some of them, but maybe it'd be nice to go through them again,
Sure.
or some of them again. So, in your experience, Dr. McClellan, is the PAE procedure painful for patients? And what
So,
do you tell
I
patients?
say this to every patient in the consult. We give everybody Valium pretty much. If you don't want Valium, you don't have to have it. I have had a few guys who wanted nothing. In fact, I had a guy yesterday who did the whole procedure with nothing. And that's okay, because the only thing that really hurts about this procedure is the lidocaine I use to numb up the skin right where the puncture site is. So that's going to sting and burn for a few seconds when I numb up that tissue. Once I get into the artery, you won't have any sharp pain. Now we do have Versed and fentanyl available if you need it. If you feel uncomfortable during the procedure, either anxious or something's hurting, tell the nurse, because we'll deal with that discomfort at that time. I have a number of guys who come in who have chronic back issues, and laying on a table for 45 minutes to an hour can sometimes, make their back really hurt. We have different drugs for that. They tell us that right when you come into the department, and we'll start you off with some medications that'll help relax your back and take care of any back or musculoskeletal pain. So those are not procedure related pains, but if you have discomfort, we want to know about it, and we can deal with it during the procedure. The only thing that really hurts about this procedure is that initial numbing. The contrast can feel warm, and then there's two parts of this procedure where you might have a burning sensation in your penis for a few seconds. I warn everybody about that before it happens. It's what we're doing is we're dilating the blood vessel with the medication, and it can give you that sort of burning sensation. We call it the spring break sign, just to give you a sense of what we're covering. Okay. So it really is an indication that we're in the right spot and we're about ready to do the embolization, but it helps the embolization be more successful. So.
Great. You may have touched on some of this as well, but many patients are on alpha blockers or 5-alpha reductase inhibitors. Will I be able to stop my prostate medications after the PAE?
Yeah, about 90% of patients will stop these medications. I want the urologists to take those medications off rather than us, because they put you on it and they're following, the outcomes of it. If it's your primary care doctor that puts you on it, I would still touch base with your urologist, but also let your primary care doctor know you're going to stop the medication. And the reason is that some of those medications you shouldn't stop right away. And though the urologists are much more knowledgeable about how these medications really should be managed than we are, because I don't generally prescribe them. But about a week after the procedure, call the urology office and see if you can come off of it. It is actually quite helpful to the post-procedure symptoms for you to continue to take the medications you're already taking, because that'll help keep that initial inflammation period as easy to manage as possible. So it's important to keep doing what you're doing, and then ask your urologist a week after the procedure when you can stop.
Great. And I think you kind of went through your own experience
Yeah.
with after what you had after the PAE, but what do you usually tell patients about how long before they may notice some improvement in their symptoms?
Well, I think the most important thing is to understand that the inflammation peak is around 4 days after the procedure. So you're not going to get a lot better in that first 4 days or so. And that's why we have all of our medications covering that period of time. So you take the medications we give you, and it makes those first 4 days very tolerable. Then once the inflammation dies down, then we're dealing with the shrinkage. And if you shrink really quickly, it'll be a little quicker. If you shrink really slowly, it'll take a little bit longer. I felt improvement about day 5. Other people have found improvement day 2, which I find kind of strange, but you never know. Everybody's body's going to react differently. And I have a lot of guys who respond at week 3 or week 4 or week 6. And it's just because the way your prostate is shrinking and how it affects the bladder and the urethra, it can differ from one patient to the next. And so over the period of 3 to 6 months is when the urologist will sort of make a decision as to whether there needs to be something else done. So I would say definitely give it at least 2 or 3 weeks if you're not improving to your satisfaction. But you should see some improvement usually within that period of time.
Okay. How about, and you already obviously went over this. Do you have to go through the penis to perform the procedure?
No, we don't go through the penis. The only patients that I will recommend, or I don't even recommend a Foley catheter for this procedure, but in patients who have a history of retention, urinary, where you can't pee at all, and you had to go to an emergency room and have a Foley placed, the the risks are higher of going into retention after this procedure than if you were sort of just a general guy who never had an issue with that before. In those patients, we offer a Foley because if we place the Foley, my medical assistants all came out of urology offices and they're very good at it. And we leave the Foley for about a week and then we'll take it out after a week. In patients who already have Foley catheters, that catheter will typically come out around 4 weeks after the procedure. And they'll do the attempts in the urology office. Oops.
I think that if you go back, yeah, what are the risks? That's some of the questions I'm seeing here in the chat.
Yeah, so
About
I go over a detailed list of the risks after the procedure. It's basically 5 main ones. One is bleeding and bruising at the puncture site. That's the most common. It's about 1 in 200. Second one is infection at the puncture site. Basically, don't want that incision to be underwater so you don't get a skin infection that affects where we punctured. The contrast material we use has 2 complications associated with it. One of them is allergy. So if you're allergic to contrast, let us know. In general, we can pre-medicate you for that contrast allergy, and the procedure is very safe. The other thing is if you have kidney disease, if you're seeing a nephrologist, if you're stage 3B or worse, which is what we call the glomerular filtration rate, 45 or less, we're very careful about doing this procedure so that we minimize the amount of contrast used. I try to do that in less than 30 cc's of contrast in a high-risk patient to protect your kidneys. That does mean that sometimes we'll do one side and then we'll bring you back a week later to do the other side. And that's just to keep the amount of contrast used as low as possible for those patients. And then the last risk is what we call a non-target embolization, and that's what most people are most worried about. We want the particles to go to the prostate, not the bladder or the rectum or the skin around the penis or scrotum. If it goes to any of those places, it can cause an ulcer. And that's where the skin breaks down or the surface tissue breaks down. If you see anything on your penis or your scrotum about 4 or 5 days after the procedure, an area that's red or black or the skin's breaking down, give us a call. We'll have you start putting ointments on it, one of them being Neosporin. You put an antibacterial ointment, and if you need to put a lidocaine ointment on for pain, you do that 3 or 4 times a day, and those ulcers heal. And the healing is very variable. It averages to 4 to 6 weeks, but really severe ones can take months, and less severe ones can be gone in a week or two. Thing is, the risk of this is probably about 1 in 400 to 1 in 500 because we do things to minimize that risk during the procedure. If I see a branch going somewhere where I don't want the particles to go, I'll plug it up with a metal coil. If I can't do that, I readjust where I inject or how I inject or what I inject to minimize that risk as much as possible. So I've done over 1,000 of these cases. I think I've seen 3 of these. Okay, so just gives you a sense of, yeah, it happens. It happens even when we're trying to be careful. And the main thing I tell everybody with risks and outcomes, anything that bothers you, call us, because I can minimize the risks a lot, but I can't make them zero. And I can't fix things that I don't know about. So.
yeah, and I got some of these questions in the chat about how long will it last, and I think maybe put that in the context as well as some of the other options, even
Yeah,
surgical options.
all of them have durabilities of around 5 to 7 years. Now, some will say they're 8 years, some will say they're 4 years. So actually, and it's pretty variable even for prostate embolization, because if I treat a 500-gram prostate, it may last 4 years. If I treat a 60-gram prostate, it may last 5 or 6 years. But you got to understand what's going on here is we can do a lot to a prostate, but we don't really want to take it out. If you took the prostate out, then your durability of symptoms has more to do with your bladder than it does with the prostate because prostate's gone. That we don't do unless there's cancer in the prostate, typically. And what happens if you treat the prostate, whether it's surgical or with a PAE, you get the gland to shrink, you get the big part of the gland taken out. That tissue is going to grow back. That's what happens to prostate glands, is they will grow back. And over 5 to 7 years, that gland will come back to the size that it was before, and it may push on the bladder again. Now, what I tell most people though is that when we do a PAE, the gland shrinks 20 to 40%, and then it starts growing back 5 or 6 years later. There are some times when that gland grows back and it doesn't push on the bladder that much. If that happens, you're not going to have symptoms. And if you don't have symptoms 5 years, 6 years, 7 years down the road, you don't need another procedure. So not everybody comes back. I don't know the percentages of returns because I've only been doing this with this company for 2 years. But it's not that unlike any of the other procedures as far as durability goes, and it's just because that's the nature of the biology. So
Um, yeah, maybe go forward just so we can have the other slides, but
there you
there's
go.
more questions in the uh okay, we can touch on these too, I guess. You covered a lot of these. Is PA covered by insurance?
Yes, and our team in Maryland pre-authorizes all of these procedures for all the centers around the country. So we usually need about 2 weeks to do that process from the time we do the consult to the time the procedure gets done. I'm typically scheduling 4 to 6 weeks out now, so that gives plenty of time for that team to do its work.
Can the procedure, so you mentioned this in the durability, but the procedure can be repeated, also doesn't preclude you from any other treatments. Unlike some of the resective procedures that you discussed, will PAE affect my sexual function?
It usually does not have any negative impacts on erectile function or ejaculation. It's actually one of the reasons a lot of people will choose this. The it's really not a negative impact on your sexual health.
Um, what should I do to repair? And I think you kind of touched on a lot of this as well.
Yeah, I would say when we do the consult, we talk about blood thinners if you're on it. If you are a patient who's yet to do the consult with us, bring that up. Tell them, hey, I'm on Xarelto because I had a pulmonary embolus and I'm going to be on it for the rest of my life, or I'm on it for AFib. The guys that I don't take off blood thinners are the guys who've had recent strokes or recent heart stents placed. Because with the new closure device that I'm using, I don't need to take people off those blood thinners. And yeah, you're going to have a little bit more bruising, but you won't have any major complication related to the puncture site with this closure device, even if you're fully anticoagulated. So it's just something I want to know when I do the consult, because when I do my note after the consult, I will put all that information in at the bottom of my note, and it helps my team in getting you pre-certified for the procedure.
Um, I think you've answered some of these others when you can resume activity and how do I get started. Maybe go to the next slide so we have that up. I kind
Yeah.
of there's some good questions in this chat that you don't always get every day, so I wanted to bring those up. There's a person in the chat here who said, I've been hearing about using super glue or cyanoacrylate instead of microspheres. They think this may include more completely giving better results. I can speak on that. I know the person who is primarily doing that up in New York. And prior to that, he was doing coils after he did his PA. I mean, all the evidence that he shows thus far shows that it works well, but there's no evidence to say it's any more durable. And as Dr. McClellan mentioned before, that this procedure has, its shelf life. It's not that necessarily blood goes through the beads again, but usually it's that the prostate over time will recruit more blood supply. So whether you use glue, or you use those beads, that's what's going to happen over time. What ends up happening though, and this is kind of how it played out with the idea of coiling out after doing their prostate artery embolizations, is it makes your repeat cases more challenging because you can't necessarily get to where you could have before. So, short answer is glue could be a fine option, but it may make it harder if you need a retreatment in 5 to 7 years, or when you need a retreatment in 5 to 7 years or longer. Um, Another question that I thought was pretty good here in the chat is I had a Urolift, or a bunch of these patients had a Urolift in the past. Do I need to do anything prior to getting a PAE if I've had a Urolift? What do you think about that,
No,
Warden?
it's useful for me to know. If you don't tell me and I put you on the table and I X-ray you, I'm going to see the clips anyway. I'll know then. It's actually doesn't really impact the procedure at all. And it's in some ways it's like anything with the urologic approach to prostate. Just because you had a Urolift before, doesn't mean that if it's growing back that you can't do a TURP. It's just good for the urologist to know because they'll plan their surgeries around that. And the same thing is true for us. There's nothing that has been done to your prostate before that will preclude me from doing this procedure.
Mhm.
So,
Great. Yeah, and some other questions. We got a few questions that kind of similar, but impact on PSA. Maybe speak on that, on
so yeah, I mean,
prostate artery embolization and PSA.
I talked about that a little bit. With the prostate, when we do the embolization, it shrinks over a period of 6 months. So you're going to get a new PSA 6 months after this procedure. And your urologists all know this, and they all do this routinely. So, and that new PSA is the new baseline. Because if the gland was 100 grams and the PSA was, say, 10, just for ease, when it's 60 grams, it's going to be 6. Okay. So, because it's a volume related enzyme. So, if the gland is 40% smaller, the PSA is going to be 40% smaller. And so they need to get a new baseline so that when they check it 6 months after that, they're comparing to something that's of the same size in order to do the screening properly for prostate cancer. So
Mhm.
it will shrink, it will reduce the PSA, but that's just a factor of the decreased volume of the prostate itself. Okay.
Right. And I think that kind of segues. There were a few patients saying impact of PAE and prostate cancer. We know that, and there's some good data or literature out of Moffitt, but we know that prostate artery embolization doesn't negatively or increase your risk of prostate cancer, or cause progression, even if you do have prostate cancer. And one other point is we oftentimes will treat patients who have prostate cancer and they're on not even going for radiation, but on active surveillance, but they have um, enlarged prostate, benign enlarged prostate with superimposed prostate cancer that they're on active surveillance for. And there is actually a spike in PSA immediately after the PAE, which is attributed to what Dr. McClellan was talking about before, that inflammatory phase. But your urologist would know. The urologists that we work with here, they're very knowledgeable and they know kind of the whole what to expect after a PA. So as Dr. McClellan said, you're going to get that reduction in PSA because it is a factor of just overall the gland size. But immediately after the PA, they may see a spike, and that's important for those patients under active surveillance.
Yeah, and I would add our practice here in Colorado, we share the building with the radiation oncologists in the south side of Denver. So we have a certain percentage of patients that are sent directly over from them because there's data from the radiation oncology community that shows that if you do the embolization before they do their radiation therapy, that their urinary symptoms after radiation can be improved. And the other reason that Dr. Lewis will send us those patients is because if he's got a big prostate and he's trying to plan his radiation fields around your prostate cancer, if I shrink the prostate by 20% or 30% or 40%, it gives him extra room around the prostate for safety that lets him do the radiation where he wants it without injuring any of the structures around the prostate or the lower part of the bladder. And it helps him with the planning he needs to do for his radiation therapy. So he's been very happy with the results after the embolizations. I think we've probably done close to 20 patients for him in the last 2 years. So it's a niche area for what we do, but it's an area that I think adds a lot of value to what the radiation oncologists and the urologists who are managing the prostate cancer can do.
Some of these questions here are probably more like individualized. So I would encourage you if you have any questions or any doubts, if you may or may not be a candidate for the procedure, contact information here is on the screen. I would encourage you to make set up a consult. Dr. McClellan or Dr. Hart, I'm sure would love to speak to you individually and go over your case. But yeah, this has been a great turnout. A lot of engagement. Anything else you'd like to add,
Yeah, I
Gordon,
mean,
before?
for patients who have not done our consults yet, I want to emphasize, we're in Denver, we're out west. I mean, Sonny lives in Metro, or Alex lives in Metro DC, so everything's, within 2 miles, but takes 45 minutes to get there. In the West, we're very spread out, and we know that. And we know that we've concentrated this center in the southern part of Denver, and a lot of you guys come up in from the northern areas, and that could be a long drive. So for consults, we will mostly do these over the telephone because I certainly don't want somebody driving over the mountains to have a conversation with me that I could have over a phone. The only thing I will do additional in person is I will examine your pulses. I'll look at the back of your throat. And those are the additional things that happen when somebody comes in person. It's a very limited physical exam that, quite frankly, is a physical exam I can do on the day of the procedure. So we've had patients come in, up from Pueblo or down from North Dakota or even Nebraska, and those folks, it's just way easier to do things over the phone. So write this phone number down, keep it with you. If you want a new consult, we can do a consult with you. If you're not seeing a Colorado urologist, it's still okay for us to do a consult for you because we'll reach out to your urologist as well. I've got a guy I did a consult on yesterday, who's part of the university system, but I do more prostates in Colorado than anybody else in the state. So the experience is valuable. Dr. Hart is the same. We are probably the top two volume performers in the state. So if you get this done here, we will coordinate with your main urologist or your primary care. If we need to get records, we'll request them. And if you don't have a urologist, you can still do the consult with us, and we'll set you up with a urologist because I want to make sure I've got a urology partner in this. I want to make sure that we'll find out where you live and what's convenient for you, and we'll get somebody who you can go see who can make sure they're going to stay on top of PSA and cancer risk and all of the other general urologic health. That if you've got this problem, you want to make sure any other urologic issue is at least being watched by somebody who's an expert in that area. So.
Great. Well, thank you so much for everyone tuning in. You will get an email after this that will also include this talk with the slide deck with the recording as well. But like I said, if any questions or any doubts, Dr. McClellan, Dr. Hart would love to see you guys in person. Thank you, Gordon. Thank you, everyone, for joining, and have a wonderful evening.
Thanks, everyone. Appreciate it.